That's not easy to monitor the actually of the suspect you guys like. Yeah, I feel here. And it's I just get that understanding of that China trust. I think I can handle this. Just fantastic. I can handle it.
Yeah, well, they do. Yeah, it's mostly toxic. Because those guys are making our life in practical. Yes, it's fine. Yeah. I see it. Trace probably fun. Don't make fun. I mean, we did a sort of a third talk to one big talk, so we can't. And maybe just some tech, you do that advanced.
Good to go. Just gotta use the slide advancer. You can use the arrow keys or this thing.
Yeah.
Or this thing. That's a really like, there's a time. You don't see the time. Stand there and picture.
Oh.
Yeah, why else do
Well.
it's long.
That part is just.
Oh my god, my answer is new. So we had the
So the same. Sometimes this is really awesome. You got seating ranking storage. My ears. It's just how they get it on. For example, and I found a bag of gummy bears. Yes, and I talked to our stores.
really? It's not that ambiance. Is this ambiance?
Sure, that was quite some obvious. Yeah. Yeah. Sure.
Unless like I took a picture that has a like a audio recording behind, but that's not
Oh.
that's not our music that I can go.
Oh, no. Yeah. We're all set up in here, recording, slides are up.
The recording?
Well, it's not that I'm recording you. It's that camera's recording you. So we're recording here. Slides are up and they can hear you. Perfect. So it's okay. So what's watching out when there's this dog with all that multicolored little gummy bears? Yes. You will have one moderator. I'm the moderator, and Tim will come up to kick it off. Although I was talking with them, and I think they are. You can start when
1:31.
you can start whenever. Yeah.
All right. All right, I'm coming for and off.
So she's really our favorite. So.
All right.
More to say. And then there's
All right. Good afternoon, everybody. Good afternoon. Yay. Welcome everyone. Thank you for choosing this session. My name is Julie Parent. I use she, her pronouns, and I work at the Vermont Child Health Improvement Program. And I'll let Mariam introduce herself.
My name is Marianne. I am Executive Director of UIRC, which is a new nonprofit organization that was just formed, and I'm here to present with Julie. So,
And we just want to acknowledge another person that's not in the room today, but it's on the virtual room, Laura Penton-Ryder, who works for the Vermont Child Health, the Vermont Department of Health, who is here and has been part of this project. So maybe just a little bit of jargon buster to start with. I realize that some folks in this room may not be necessarily working in the space of perinatal care. So by perinatal, we mean the time of pregnancy all the way to 1 year, 1 year post-pregnancy. So just want to put it out there, as I feel like sometimes we're in a loop and then we talk about this all the time, but then folks might not know. And then we're going to zoom in. So really looking at mental health service access and utilization. And again, zooming in even more and really looking at the experience of refugee women resettled in Vermont. No disclosure. Learning objectives. So super quick. Mariam's going to take us through some of the common service barriers and enablers or helper associated with access and utilization for mental health service for that population. And then we're going to share with you what we've learned when we talk to women, refugee women, about their perspective on what could be some actions, some activities that we can do to really help them and their community. And then we have been involved in like some activities that are related to this, and we just wanted to share that. So just for context, for context, taking it from like the national level, there is 1 in 7 women each year that are affected by perinatal and postpartum depression. And I'm not sure if my data here is the latest, so maybe in the room there's even another number. But bringing it a little bit closer here in Vermont, perinatal mood and anxiety disorder, which is known as PMAD. You probably hear us also talk about this acronym a lot. Affects more than 25% of pregnant and postpartum people during that time frame of 2018 to 20. And our passion for working on this topic really comes down to that last bullet, is that the literature so far tells us that refugee women and immigrant women that are resettled in a country like United States have higher risk for perinatal mental health problem than the general population due to their resettlement to a country. Imagine coming to Vermont in February, and then all those structural inequality that we've been talking about all morning here today. It makes that population more at risk. Okay, so another little bit of context, just to orient you to this project. So the health department, through a grant funded project called STAMP, which was across Vermont, did a lot of work in that space. In 2020, during the pandemic, had done a study project, a research project, qualitative, where they interviewed 28 women with perinatal mood and anxiety disorder. And one of the limitation of that project, first, it was during COVID, so very difficult to do, but they were still very successful and were able to talk and have deep conversation with 28 women. But what they had noticed is that they were not able to outreach and really talk to people that represent a diverse population of Vermonter with different language, etc. So the real deep dive into this project was really to kind of address that limitation. And then I've included here the partners that were part of this project. So Vermont Department of Health, the VCHIP where I work, the Department of Mental Health. When you do something like this, there is a lot of talk with cultural worker, people that work in the field. And thankfully we had the family room at 20 Allen Street. And this is a picture of the back door there that really kind of embraces this project, and we partner with them. And then you may wonder why there is a London school there involved in this, is that this was part of a research project for the purpose of a requirement for a graduate program that I was doing. So it came with advisors from that school who are working in a lot of similar topic, but mostly in low to middle income countries population. So what we did, and I'm not going to bore you with all the methodology because it can be boring, but what we did is that we took that parent study, we looked at it, we consulted with those that had created the questionnaire, and we really duplicated it and create the same model qualitative research study, building a questionnaire, building a written consent form, eligibility, really meeting with a lot of folks in the community to find out how to talk about this with that population and kind of adapt that questionnaire and those tools. We had a recruitment flyers that was translated, that went across the designated mental health agency, community health centers of Burlington, family room, all the place where people could connect. And then through our work with the cultural broker, if you look at the little visual there on your right side, we also tried to break down using this very simple visual when we met with the woman to talk about mental health. And Mariam's really going to dig a little bit deeper into that, but to really break it down and not use like complex medical term to describe this kind of illness, but really talk about it through the symptoms of how a person can feel. And then, you know, for us who works in healthcare, screening, referral, treatment is like, it comes like this, right? It's part of our language, but try to use picture to describe what we were really talking about during the interview. So that's that. All right. And then, so what we did, we were able to connect with 12 participants, 12 women who live in Vermont, mostly based in Chittenden County, but also outside of Chittenden County. You may wonder about the 12 participants. So our limitation with our ethical approval that we had received really bound us to just work with 12. It would have been wonderful to be able to work with more people, but we were not authorized to do that. All the women that we interviewed had fled a country due to war or conflict. They were from Afghanistan, Nepal, Bhutan, Sudan, and Somalia. 5 of them spoke English, 7 had limited English proficiency. Everyone reported some symptoms of perinatal mental health problems. Some had access mental health and some did not. And then I'm going to turn it over to Mariam, because I think, Mariam, these are kind of the next 3 slides are really about common service barrier and helper in terms of accessing service. And Mariam is someone that works directly with these these women as an interpreter, as a cultural worker, as different role in the community. She's part of the community. She works in clinical setting, community setting. So really kind of bringing in here from a lived experience of a person that works with that population.
Thank you. All right, so I'm going to turn, where was I? Okay, so we are talking about the common barriers, which is usually people in our community, and this goes across all immigrants when it comes to mental health. When you say mental health, what they're hearing is actually mental illness. But in the service providers world, they use mental health, which they mean in a good way, but what they're hearing is actually a mental illness. So the mental health issue in our community is actually a taboo. People don't like when they hear mental health, they say like, I'm not crazy, this person is crazy, or this someone that cannot take care of themselves or their daily life. And the other one is a cultural broker, the first being a language barrier. Most people, English is their second or third language, and the subject is taboo. They don't usually have a words to express what they are feeling, their anxiety, or that terms that is being used in the medical setting. And so when since they cannot communicate, healthcare providers, clinics, they don't bring up those issues because they don't have a word to use for. And also the interpretation and translation services in Vermont, what I have seen in my, I have lived here for almost 18, 17 years, we don't have a lot of trained interpreters in the state of Vermont, particularly in my speaking. We don't have qualified that are trained, and also in the mental health forum that are trained. We don't have that in Vermont. So then that speaks, and most of the communities that in Vermont, I would say MIMA is one of the highest, which I think is now changing, is one of the highest population in the refugee. And so I think that's changing recently. And the other one is a stigma in our culture, because talking in mental health is not like something that's been talked as a family. So when I work as an interpreter, when I see patients, especially younger ones, they say, I'm experiencing this, but we don't talk about this in our family, but I'm experiencing this. And then I had someone said to me, I'm experiencing this, but I can definitely feel my mom's also experiencing, but we don't talk about it because it's really not even a topic to talk about in the family. And then we usually as a community, people get stigmatized by having a mental health, and then that they cannot take care of themselves or do their daily life. And also service providers in the refugee community mentor, they have to really, really get to know you before they open to you to say what they're really feeling. And I think maybe some of you guys know, working with the refugees, they really have to get to know you before they open up, especially when talking about mental issues. And then the challenges associated is navigating the healthcare services related. So forget about mental health, like navigating the healthcare system is just like a barrier for people who don't speak and write the language. And even like picking up the phone and calling the doctor is sometimes, oh yeah, we have interpreter, you can breast this, but you have to understand for you when they say breast this, if you need an interpreter, if you don't even understand that, it is a challenge. So then, and then for people, they have other priorities other than mental health. Is like their life stressor is like housing, paying their bills. Some people, usually people from Africa, from other immigrants, we support our people back home. So the money that I earn, it doesn't go to my bills. Just I worry about my families back there. I send my money there. So people are worried, like constantly getting phone calls, supporting families back home. So that's what they're worried about. So mental health is like the last thing that they can think of. I think that's all I had. Right? All right. So what do we need to do now? 5 minutes. Okay. So what the principles for helping is creating an awareness in the mental health issues, because it's a taboo, nobody talks about it. We need to meet people where they are, we go to them and talk to them, like create this space of like talking about what they don't have to have mental health, but going to spaces that they already meet. And I talked about this before, but we like going to the mosque or to the churches that they go, or to wherever they gather, and then we present that kind of like this happens. Because definitely, the children of immigrants, they're experiencing and they know it's real. But then you need the parents' consent for child to get mental health services. We're talking about prenatal, but it's the same. And sometimes it's hard for them to even accept that, to accept. So they have to see someone that they know that is going through. So I was telling the example of my cousin who come from another state 2 weekends ago, and her good friend, she had experienced postpartum depression, but this was I think it was her 9th baby, and she was like, I didn't know the thing was real. because she has seen her good friend, like she could literally not even take care of herself. And unfortunately, most of the time, the immigrants in the community, by the time they come and seek help, it's actually too late, that they need that higher care with a psychiatric care or an emergency room. So we need to create an awareness of like, this happens. And so that way, because when they know that, when they hear this talk today, and then tomorrow they experience, oh yeah, maybe I'm feeling this. I think that's what I'm having. They might come and talk to you, or find someone in the community, those who are working with the immigrants and refugees. And also important of privacy and confidentiality. I work as an interpreter, and confidentiality is the top. I cannot emphasize that enough. It's a priority. Like I always tell my patient when I interpret, I don't want to know anybody that I was even here with you as an interpreter, because people, we're a small state in Vermont and people know each other. They come, oh yeah, I was at this and this and she was there. So I give them a heads up that please, if I see you, because I'm sure I will see you outside of this, but don't even mention I was there, because I'm only here because of the language piece. Otherwise, I wouldn't even know that you were seeing a doctor today. So that's like, so we need to train interpreters in the mental health and also in general, and also confidentiality, as in our organizations. We train interpreters, and that's the top priority of keeping things confidentiality. That's the top priority for us. I don't know what else I missed. Yeah. All right. And we also, the value of culturally adaptive resources and services, and also inclusion of bicultural community workers. I think every service providers needs that in their practice. So that way, when they're dealing with immigrant and refugee in the community, they know, they ask that person, what is the best way to approach this topic in your community? And they're the best one to guide you how to implement that into the community. Right, that's well said. Sorry.
Oh, hold on.
You want to take over?
And I know you don't have a label after 10 and 5, so I'm going to go super fast. Just to summarize what Mariam said and so the last question of our questionnaire when we interviewed the woman was how would you support other pregnant and refugee and postpartum refugee mom? And just like Mariam said, and I think I heard this morning, really top priority is help address health-related social stressor, whether it's housing, paying the bill, having food on the table, making sure the kids are at school, financial stability. Always, like, it was almost hard to always veering back to that during the interview, because that's the top thing. And then when we digged in a little bit and asked, like, what could we do really to increase awareness? Again, like Mariam said, come to our community, address this topic universally in different language and plain language. And then, of course, the family room came up many, many times. So to the team at the family room, brilliant work out there, and just the availability of bicultural worker for sure. And I know we're going to run out of time, so just wanted to share super fast with all that information, what we've done so far. At least at VCHIP, is that we kind of took all those partners again together and create one wellness support video for my speaking families as a first step, because we had the resources, but to really try to increase awareness around this. And that was one step. And then, should we do one more?
Sure. So quick. So that's what UIRC is. When I was introducing myself. So we do provide interpretation, document preparation, inclusive entrepreneurship support, and bridging the gap in transition services. So the top 4 bodies, that's our active services that we have at UIRC, and we hope to expand it more. So it's a nonprofit. We have 6 active interpreters who do translate and paperwork and educate, bridging the gap. And we do like all kinds of stuff. So this is just the thing that I could think, but we do more than that. So the challenge is potential services seeker, they're afraid of being stigmatized, huge cultural differences and misunderstanding I was just giving an example. My mom's doctor's appointment yesterday, where they had this interpreter, and the person, what he was saying, because I can understand the English, and what he was translating was like totally different thing. And I was like, okay, this is a person who speaks the same language as her, but he's like, I jumped in and I was like, you need to verify when you hear something, don't just say what you think you heard. And as an interpreter, that's a huge, like you have to understand, you have to make sure you understood what the doctor or vice versa said, instead of just like jumping into a conclusion of what you think. He was talking about tumor, but the doctor was talking about sore throat. Those are two different things. Yeah, I think we ran out of
Okay, we ran out of time, but and there's two, three people from VDH here, but I just want to say VDH also really created awareness campaign around just perinatal mental health and for the whole population. So I invite everyone to go check out their resource online. They've translated some material and all that. And just special thanks to everyone who was involved in our project. Thank you very much. That's why I was told that they were on stop. Stop. There it is. Okay, for the person who asked for an encore, this is a little bit of an encore, actually. So nice call. So our team would like to thank the Health Equity Summit for the opportunity to present some of our work. 20 minutes or even 40 minutes as we combine two talks is not enough time to really do justice to this topic. So we'll go through this pretty quickly. But the work we'll be presenting this afternoon is a combination of several different components of initiatives we've been building together in order to improve the experience and the ability of our immigrant patients to self-advocate. This work is composed of team members from several organizations. I'm Carol McBride. I am an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and I work with VCHIP.
I'm Marty Churchill. I'm the lead midwife and clinical coordinator of the midwifery services at UVMMC.
My name is Amelie Thurston. I am a nursing professional development practitioner, which is a fancy way of saying nurse educator at the UVM Medical Center on the labor and delivery unit.
Still have a picture of you on my
My name's Adama. I'm a third-year medical student at the Larner College of Medicine.
I'm going to read because I do so many things. My name is Kerubo. I work with the Association of Africans Living in Vermont, where I manage casework and coordinate the community cafe within the Refugee Women's Empowerment Program. I am also a community health worker.
And then we also have two team members who couldn't be here today. One is Dr. Marjorie Meyer, who is a maternal fetal medicine specialist. And the other is Deva Savio, who works with the family room, who you've just heard about. So first, as a little bit of background, we want to expand upon the importance of addressing the needs of new American communities. I think everyone in this room is familiar with many of these needs, particularly after the last talk. So we'll just go through a little bit of background information as these communities represent many different cultures, languages, and have different barriers to care depending on where they're from or how they immigrated to this country. So Vermont has the 5th highest rate of refugee resettlement in the entire country. And between 2018 and 2022, 12.4% of deliveries at UVMMC were to pregnant people who were born outside of the United States. It's a pretty big percentage, particularly when we think of how how homogenous we think Vermont tends to be. In Chittenden County, we have a census rate where about 9% of our population is people of color, are Hispanic, or are Indigenous. But when we actually look at the birthing population, it's 19%. So our birthing population is not the same as our general population, and it's very important to consider in the experience of our patients. We have many anecdotes about poor experiences, poor outcomes, and mistrust between obstetric medical providers and immigrant patients. And we want to understand, both from clinical data and from the patients themselves, what their experiences have been so that we can improve those experiences for future patients. So looking at demographics by language, we'll just do a little bit of background information. This is a very brief sub-analysis by language usage, where we're evaluating birth data from 2018 to 2022 at UVMMC. During this time period, there were 10,343 singleton deliveries, and we looked at maternal place of birth and language. Of these deliveries, our patients had 132 individual countries represented as maternal places of birth. They reported 42 individual primary languages, and 30 of those 42 languages required interpreter services for interpretation. Oops, so sorry. I'm trying to move my notes. How do I move my notes? Technical issues. I'm sorry, everyone. What am I doing? Okay, so since I can't see those notes, very, very briefly, the main points of this slide, I want to draw attention to the increased rates of Medicaid and self-pay for patients who do not speak English as their primary language. This speaks to both income level as well as access to insurance. So much higher rates in our patients who are not English as a primary language. Other than that, they're fairly similar. Unsurprisingly, we do see a lot more people of color in people who require language services. In the interest of time, I'm just going to highlight the lower rates of preeclampsia and gestational diabetes, which are very common complications of pregnancy, and very, very normal gestational age and birth weights in English-speaking and non-English-speaking patients. This is all demonstrating that these populations are not different. If anything, the immigrant populations are healthier than the English-speaking populations based on those lower rates of complications. And when it comes to this slide, we've also previously analyzed outcomes by country of origin, and there we found significant differences across several different metrics. And as we talk today more specifically about language, I want to present the data as it relates to primary language. These numbers combine both those requiring interpreter services as well as those not, looking specifically at individual outcomes by language. So I'm not going to go through each line, but from the colorizations, I just want you to observe that there are some pretty striking differences by language for different outcomes, including Medicaid status or self-pay, whether or not patients are paras, meaning if they've had births previously, if they're receiving interventions, including labor induction, labor augmentation, or cesarean section, and also complications like blood loss. So it's not really important to go into the specifics, but it is really important to recognize that there are differences by language, and we really need to delve into this to understand it more deeply. This is Deva's slide. She's not here, so Marty's going to cover it.
So Deva Savio comes from the Family Room. We know that they do incredible work and have multiple offerings in terms of services that they provide. We partnered up with the Family Room to help us identify people to participate in our focus groups. And Deva was really instrumental in doing that. She also helped us provide childcare and coordinate within the community to serve a meal for them. And the Healthy Families from the Start is just one of the various amazing programs the Family Room does.
Okay, so topics we're going to cover, again, very briefly during today's discussion include these focus groups that Marty just discussed, labor and delivery tours, which Amelie will discuss, continuing community discussions with the Conclaves group that both Carabo and Adama will discuss, and Amelie, all of us. education, and the vision of where we plan to bring this work in the future. So first, I'll speak very quickly about the grant funding. Marge Meyer and I received a UVMMC Innovations Award, which allowed us to look at both a retrospective analysis of data as well as conduct qualitative assessments, in which we conducted language-specific focus groups to discuss experience in pregnancy and childbirth and postpartum period, both with immigrant women as well as with providers who care for them. And the objectives are to take those data, the combined qualitative and quantitative data, and identify themes and areas of improvement to be able to provide culturally sensitive trainings for our providers and to provide educational content for community members that will allow them to be able to better self-advocate and be able to be prepared for their medical interactions so that they can ask good questions to help them understand the process. So these focus groups, because we're talking about very sensitive topics, we take a lot of care to foster a safe, comfortable environment to allow for the encouragement of sharing of stories and experiences. In order to do this, we partner with trusted organizations to identify group facilitators and interpreters, and we hold our groups at the family room. Because many of our families and our patients are comfortable in that environment. We also, as Marty mentioned, provide childcare and transportation as needed, and we hire either a community member or a local restaurant to provide an ethnically appropriate meal, and then people are compensated for their time.
So these focus groups were organized around language so that we had interpreters present to help us to communicate. Carol did these focus groups along with at least one provider. I was there for many of them. Amelie was there, Marge Meyer was there. So together we asked these members of these focus groups all the same 12 questions. These are the groups, the languages in which we have already done. We hope to do 3 more, an Arabic group, is it Vietnamese, and Mandarin. We haven't been able to identify a Pashto, a female interpreter, so that one may not happen. These sessions were recorded with permission and then transcribed, and then we organized those answers based on themes. And the themes that came out were areas of needed patient advocacy, knowledge that the patients or the people of these communities needed more information of, knowledge for topics that providers needed more information about, and then how they were able to navigate or not navigate the healthcare system, and then other. So briefly, and this is very condensed, we're going to talk about some of the answers from these focus groups. So for the Swahili speaking group, under patient advocacy, they clearly did not want males in the birthing room, really wanted their privacy protected and as few as people as possible within the birthing room. Areas for more information for the patients. They didn't understand the need for induction of labor or C-section, verbalized that they felt we used too much intervention. They needed to understand the why behind our recommendations and felt like they weren't allowed to refuse these recommendations. Areas for more information for providers. They wanted providers to know that to ask each individual person what was important to them, that they didn't want to speak for everyone. And they felt that even though we were grouping them in a culturally congruent group, they said, I can't speak for my neighbor. I can only speak for myself. They felt care from providers sometimes was too rough when they were being touched. They felt providers pushed medication for birth too much. They felt like surgery for birth is only if the life is in danger, and felt like we did it too often and too fast. In navigation through the healthcare system theme, they wanted things to be explained to them before they happen. So again, anticipatory guidance. And under other, birth is sacred, and it's a sacred event for women, and they didn't even necessarily want the father of the baby there to witness what they needed to go through to give birth. So we did 3 Somalian groups. So these were grouped together as well. Under patient advocacy, and you'll see some themes with the Swahili speakers, they really felt that they needed advocates for themselves during the birthing space, either for their families, for themselves, or from a doula. They wanted to be able to say no to students or to ask for a different provider if that wasn't working well for them. They were upset about being given pieces of paper to sign and not understanding what they were signing for. That was very distressing to them. Under more information for patients, they needed to understand what was happening around monitoring, like why was their blood pressure needing to be monitored, or their fetal heart rate? Why were we inducing them? Why did we need to do a C-section? So again, very similar, needed more information about that. For providers, they wanted us to ask about female genital cutting. They felt like that wasn't addressed or even talked about, and they felt like that was a very important part of their birthing experience. They wanted connection to their providers, and they said they couldn't establish that kind of connection in a 10-minute visit. So they wanted continuity of care and longer visits to develop that rapport. Under navigation through the healthcare system, they felt disrespected for being Black and for wearing a hijab, and their assumption was that they didn't speak English. And so many of them experienced discrimination, bias, and racism with people in the room speaking in English, discriminatory against them, and they understood every word. They identified mental health and depression. It wasn't acknowledged in their culture, and yet we didn't also address it and provide enough support for them when they were experiencing that. For the Nepali group, under patient advocacy, they wanted to be able to stay with their baby when the baby was in the NICU. They expressed they needed more information around breastfeeding. That was lacking for them. For providers, they wanted providers to give as much information as possible and not wait for them to ask questions. So again, that anticipatory guidance. Under navigation through the healthcare system, they found interpreters were sometimes uncomfortable to have present, especially if they were male. So not checking in around gender and interpretive services. Under other, they felt really comfortable talking to social workers and wanted greater access to services that social workers provided. And they felt like having a baby in the United States was better care than in Nepal. For the Spanish focus group, they, under patient advocacy, in the interpretive services were a big challenge. They felt like not all the information was interpreted, similar to your experience, Marianne, and the gaps, and not everything was accurate. And they felt like if they spoke one word in English, then the interpreter perhaps would. The one shared an experience of them hanging up on the iPad. Loved it when their nurse spoke Spanish, and loved it when they had the same, continuity in the interpreter throughout their whole pregnancy, an in-person person. Increased knowledge for patients. To be able to ask for a different interpreter if it wasn't working for them. Knowledge for providers. They wanted more information, written information translated into Spanish. Navigation through the healthcare system. They really needed help navigating health insurance. They felt like they got bills that they couldn't pay. Under other, they believed that prenatal care, good nutrition, vitamins, staying healthy were all vitally important to growing a healthy baby, and they wanted access to these things. They felt like overall they were listened to and treated well in the hospital.
Okay. So switching gears a little bit, I'm going to talk about some of the work that we've been doing on labor and delivery. So I've worked on labor and delivery for 17 years, and historically, we've been very casual about offering tours of the space. Patients are very interested in seeing the space before they give birth. I think it alleviates a lot of anxiety for folks to know what to be able to expect. And usually, we always just welcomed people to come up, and we would just pick a nurse who wasn't busy at the moment and just kind of tour you around and answer questions, 10 or 15 minutes. I noticed that we were always giving tours to English-speaking families. We never had patients come up with an interpreter. And so I just started to be more aware of this gap, that we weren't in a spot to be able to provide this anticipatory guidance for patients that didn't speak English. So I collaborated with nurses at the Community Health Center in Burlington to start organizing language-specific tours of labor and delivery. And they became much more than just tours of the space. It was really a much more comprehensive, like 1.5 to 2 hour session with interpreters where we would definitely tour the space and talk about the medical equipment and like what they would see in terms of monitoring, what routine workflows to expect when they come up to labor and deliver, but also just left tons of time to have questions and answers. So that was super successful and people were very interested in it. It was going great. And then COVID hit and everything came to a screeching halt. All tours stopped. It was a big gap. People definitely missed the opportunity. So we pivoted to Zoom tours and they were, again, hugely successful. I was like shocked, like 30 families would log into a Zoom tour, twice a month. It was pretty remarkable. And then we started working with our language access department to provide interpreters so we could get back to the language specific tours. And that was all very successful and it was working well. But for folks that English was not their primary language, like there was a lot of connectivity issues, just like getting logged into Zoom, or you're logged in, but then you can't get the audio connected. Like we did find there was a lot of roadblocks and it wasn't always super smooth. So in the work that Marty and Marge and I had been doing with Karubo at AALV, they kind of linked us with the family room as well. So Deva Savio and I started collaborating on different projects, and this became one of the big projects that we're working on, is creating these tours in video format. And we're working with the Vermont Language Justice Project to create these videos in the 10 most commonly spoken languages and also American Sign Language. And the hope is that these tour videos, again, it's not just the tour, it's very comprehensive and we explain a lot. We're hoping that they can be used in a lot of different settings, childbirth education classes, prenatal appointments, to help patients prepare for what to expect, but to also plant those seeds of what questions to ask, what things to talk about with your provider, like how to start advocating for yourself and setting the stage for the type of delivery you're hoping to have before you arrive on labor and delivery. And that is that. Now I'm going to pass it over to Bo to talk.
Thank you. I saw that we already have had the the marker where we are on time. So I'm going to read this really. I hope you can understand what I'm saying. We are. Okay, thank you. So this
We're good.
Initiative named Community Cafe, in order to avoid any association with the stigma and shame tied to the atrocities these women experienced during war, supports mostly the East African women who are Swahili speakers and who are survivors of war and violence by offering a safe space for healing. Healing is the word that should resonate with you because you're converged here as healers. Also for community building and access to critical resources that are very, very difficult to navigate. So in my role as a cultural advocate, Swahili interpreter, community health worker, I try to bridge these gaps, which are even, for me, very difficult sometimes because of the bureaucracy and just so much paperwork that also sometimes gets in the way of treatment. So the dominant factor is that they speak a language that I speak, so I'm able to reach them directly and help them in whatever they need. So my work really emphasizes on collaboration with the UVM Birthing Center, these ladies here. I gotta tell you that when they come in those sessions and sit down with the ladies, they get direct service right there because they get listened to. They get to say what was scary for them, what they had never had, diagnosed from the refugee camp. What is standing in the way? Then the video, they look at it and they're not so scared anymore to go to the birthing center. They know that these are the same people that they will meet there and that they will be taken care of. So through these listening sessions, we have created the platforms where these women can share their healthcare experiences, where they're helped, to address their disparities in diagnosis and access to care, there's precipitation of pain. It's been said that, Black people can withstand pain more than others. It's a real thing. And so this collaboration has led to more compassionate listening and being acknowledged and being seen as people who need to be treated a little bit differently because they have with a trauma lens. Their experiences it's not one model fits all. Theirs is a little bit more complex, and there are layers of complexities that come with them. So I love where I work because it's like a one-stop shop. I can go downstairs to the family room with someone who needs care and who needs to see those videos. I can go to Dr. Green's office when I am helping someone who is expectant. I can send her directly to the birthing center because I can call, hey, so-and-so is coming, la, 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 la. And they can go there directly without the bureaucracy of trying to call and being told that you need to press 1 in English when you're a Swahili speaker. So those are the things that these women deal with. So in summary, I'm just saying that these collaborations, they're more than just improving access to healthcare. It's about building trust. It's about fostering understanding. It's about creating lasting change. And we're all about empowering these women. Women are strong. Women can do so much if they feel empowered. They don't want to feel like, they need to be helped. These are women who have survived in an environment that has less, like they can make soup out of pots, right? So why would there be an expectation that they need help here? They just need empowerment and to be made to feel that they have an autonomy over their everyday lives. They deal with so much where even when they go back home, they are living in male dominated environments where they don't have any say to, do I want another baby? It's just they're forced to have another baby sometimes, even when they are so tired, have already had 9 babies, and they're struggling with that already. So compassion, care, love, surrounding them with that's all they need. Thank you.
So, as Kerbo spoke to, this is the group that she leads. She's an amazing facilitator, and we were so honored and blessed that she welcomed us into the space. And so the team of Marge Meyer, Marty Churchill, myself, Karen Vastine, Carol, and most recently Adama, we have been invited to this space. We meet, we've been going for about 2 years. We meet, I would say, once a month on average. When we first started, we were like, okay, let's make our PowerPoint. We got this topic. We're going to really break it down. And I mean, I think that it was well received because we were just there to provide as much information and education about pregnancy and the birthing experience as possible. And so, I mean, people were interested, right? Most people are interested in that topic if you're a birthing person yourself. But we really quickly realized that these were just going to be very organic conversations. And so the topics just kind of evolved based on the conversations we were having, the questions that were coming up, and just the topics that people were expressing interest in. And I think what we learned very, very quickly was that the key to having an impact was just the commitment to being there and the commitment to creating a space where we were just open to hearing their stories and validating their experiences and just taking the time to build that relationship and build that trust. And like Kerubo said, it's, our focus really is we want to fix the system and we want to increase access and we want to fix interpretive services. But really what we want is just to create, a space for healing as much as we can. And so I'm going to pass it over to Adama, who's going to just speak in a little bit more detail about some of these sessions and a topic that she's focusing with the group.
Thank you so much. I'm just eternally grateful to be invited into this space, to be led amongst these women who are doing the work and doing it with passion and care. The topic that I was really focused on was looking at reproductive pain, menstruation, and sort of chronic pain disorders related to gynecologic issues. Pain disorders we think about are endometriosis, pelvic inflammatory disease. But before I go into all the details, I just want to again emphasize the words that were said, acknowledging just the sensitivity and vulnerability of the women that were able to open up and share their experiences. This is not an easy topic to talk about. There's a bunch of taboos and stigmas related to talking about menstruation and periods. So just wanted to make sure that I am focalizing the importance of highlighting these stories and just their willingness to share it. So as I mentioned, just the goal of the project was to really particularly look at reproductive health and focusing on gynecologic disorders that are associated with chronic pain, but particularly focusing on marginalized groups within our community, that it makes it another layer of difficulty to accessing that level of care. Thinking about reproductive disorders related to pain, endometriosis historically takes about 7 to 10 years to diagnose. So think about on top of that, having a language barrier, not being familiar with access in the healthcare system. Those are important things to think about. So this project in particular took on a 3-phase longitudinal approach. Questions, as I emphasized, were, I had a whole list of questions, but they all went into a different tangent, or there were stories that were talked about that were powerful within themselves, and staying to a script just doesn't really capture the nuance in those dialogues, but there was structure. Phase 1 really was looked at to kind of identify reproductive health perceptions, exploring the cultural significance of menstruation, identifying what pain management approaches, whether that be like NSAIDs or just kind of struggling through the pain and not really knowing what to do next, highlighting the barriers that are present in healthcare access and understanding the nuances with emotional and psychological impacts of menstruation. That dialogue sort of merged into phase 2 questions that also led into tangents of understanding just the overall significance of the healthcare system and language barriers, financial constraints, understanding navigation that plays a role in limitations with accessible care. And phase 3 is just what everyone emphasized, is promoting healing and uplifting communities of women to share these stories. As I mentioned, talking about this within, I'm just a medical student. I just learned all these things early on, but I understand the significance of sharing the impact of these stories because it's so permeated within our culture to not talk about it in our society in the US. So imagine not having the spaces to talk about it. So that's sort of the direction for phase 3. So emphasize that, like, just like they said, focus groups primarily were the Swahili refugee women of reproductive age. Phase 1 had 12 participants, phase 2, 13. Caribou served as a facilitator and was able to capture just the beauty in these discussions, but also highlighting the trauma in these stories that were important to gather the context necessary for these dialogues. So for phase 1, there were 4 themes identified: experiences understanding menstruation and first periods. Many discussed the limitations in knowledge on receiving their first period, which led to confusion and fear. And then the overall lack of information due to cultural taboos surrounding just the discussion of menstruation. The second theme identified was stigma surrounding menstruation. Many noted that within their communities, there was feelings of shame and isolation that often limited conversations that would take place, making it difficult for them to ask questions or seek advice about the changes that were happening within their bodies. The third theme identified were the physical and emotional impacts, detailing severe pain, debilitating pain, nausea, discomfort associated with menstruation, left many feeling just sort of the disconnect between whether they should access medical attention or if they actually inform their doctors about this care. Many were met with that this was just a common occurrence and wasn't cause for concern. And because of this, many were either prescribed family planning medications or pain management medications without the proper education about why they were taking these medications, which is important because there are so many reasons why you take medications related to your reproductive health, and having those conversations is difficult to have. The fourth theme identified in phase one was the expression of frustration and the lack of faith in the healthcare system, and which sort of led into phase two's lines of questions that led into large-scale discussions describing multiple visits related to visiting the clinic and not feeling like their concerns were adequately addressed. Many felt like they were impersonable and didn't actually get to the root cause of the health concerns that they identified. And many reported racial discrimination and not feeling like their care was actually taken seriously until it was an emergency. And even then, feeling like there was a disconnect in the care that they were receiving. So big takeaways: lack of knowledge, cultural barriers, healthcare distrust, discrimination, financial constraints all led into line of questionings for phase two. So for phase two, language barriers, as many of us have highlighted already, interpreter services, translation services, there was already a language barrier in just even the initial phone call with accessing an interpreter. Some discussed limitations with even having the correct dialect within the Swahili language barrier that made it difficult for them to even feel like they could speak with interpreters. Many faced challenges related to navigating the complexities of the healthcare systems, and the language prompts that were used just on that initial phone call led to a lot of frustration and discouragement. Financial constraints, barriers related to medication costs, insurance complexities also made it difficult for them to receive the care that they needed. And just navigating the complexities of the healthcare system, especially with accessing specialized care, with diagnosing things like endometriosis, takes surgical exploration. So accessing a specialist that is trained in this takes a long time if you're even just identifying where the pain symptoms are coming from. So that presented an additional barrier. So phase two takeaways: language barriers, financial constraints, system navigation, all important things to highlight, but also so difficult to tease out and be able to fix in a day. And I'm so lucky to these women for identifying that this is something that is going to take a long time to just address and to make massive, massive changes. But it's important to start that dialogue there. And that leads into phase three, which is continuing to maintain and promote healing within these communities. Talking about this openly and candidly within just the community of Circle of Women, that takes a lot of vulnerability within itself. So having these spaces and dialogues allows it to normalize that these conversations are okay to talk about, acknowledging the systemic limitations and continuing to affirm the experiences. Caribou and Amzi discuss more.
All right. So next steps in education. So I work in nursing education, that's my role, but I find myself participating in provider education, and more so just because it's really like my area of interest, patient-facing education. So one of the ways that I can have an impact on kind of as many people as possible is through my work with Vermont A1. So A1 is our national nursing organization. It's the Association for Women's Health Obstetrics and Neonatal Nurses. And there is a Vermont chapter, and I sit on that board. And we hold annual conferences for birth workers all over Vermont and Northern New England. Last year, the focus of our conference was navigating inequities in perinatal care. And you can see there kind of the list of topics that we discussed at our conference. And one of the most impactful sessions was a patient panel, and it was all Dava at the Family Room helped us identify folks in the community who would be interested and willing to come up and share their experiences birthing at UVM. And you know, it was the panel was facilitated by Dr. Marissa Coleman. So she's like extremely skilled and trauma sensitive. And there were some like sticky moments in the conversation for sure. Some questions asked from the audience that were kind of just like recentering the nurse. We're recentering like our experience. Marissa did an amazing job bringing it back around to focusing on patients. And I think just it was the one thing that I really took away from that panel was back to this relationship-based care. Like we had folks, they all shared positive and negative aspects of their experiences delivering at UVM. So it certainly was not all negative, but what really struck me the most was like, regardless of what language they speak, regardless of their country of origin, of their religion, what was very clear was that everyone had very unique personal hopes, expectations, desires for how their care would be delivered to them. So, it's kind of like the more we learned about it, the more it was like, yeah, there really is no like cultural guide, to taking care of people. It comes down to getting to know each individual and what they need. Luckily we work in when we work in a birthing environment, people often come in with a birth plan or at least some kind of thoughts around how they want their experience to go. And so we are open to like trying to accommodate people's hopes and dreams for their birth. And I think it's just, you really need to make sure that even if your patient doesn't come in with their birth plan written to share with you, that you're still taking the time to figure out what is important to them, what you need to know about them in order to help them have the kind of experience they're hoping to have. This year, we're hosting our Vermont A1 conference at the end of October. And the focus is on integrating respectful and trauma-informed approaches within perinatal care. So we're having workshops that are, if anybody saw one of the talks this morning with Anissa Stewart, she's giving a talk that focuses on like the trauma that birth professionals experience and how we can support each other. And then the rest of the day is focused on delivering trauma-informed care to perinatal patients. And there is also doing some of the folks that are coming from Texas are going to do a grand rounds for our OB providers on that same day. And then we're offering a series of virtual webinar-based workshops with the same group throughout the rest of this year. And one of the really cool parts is A1, our National Nursing Organization, has a variety of toolkits and all sorts of different like high-risk OB topics. So they have hypertension toolkits and postpartum hemorrhage toolkits, and they have a respectful maternity care toolkit. So one of the folks from A1 that developed that toolkit is going to come to our conference and give us a whole presentation on implementing that toolkit in your practice area. And through a partnership with the Vermont Department of Health, we're actually able to offer 2 complimentary seats for every hospital and clinic, really, that's providing perinatal care throughout Vermont. So we have 2 representatives from inpatient and outpatient areas all across the state that are kind of tasked with coming and learning about this and then implementing this in their spaces. And then Vermont A1 will also host quarterly meetings moving forward to bring everybody back together and just kind of collaborate, brainstorm, make sure we're not working on things in silos and that we're just continuing to move that work forward. That's just about the toolkit. But basically, it's just kind of recognizing our biases and breaking those down and treating people as individuals. And it's just a lot of all of the things that we've been talking about today. And then just another thing that I'm just trying to really push and utilize the resources that already exist at UVM Medical Center. Our DEI department has created some really, really impactful courses that are, you take them online, but they're live, they're facilitated live. So they're cool because you end up being with people from all across the health network in all sorts of different roles. Doing all sorts of different stuff, and there's breakout sessions, and it's all very interactive, even though you're doing it on your laptop. So we're just trying to push those, specifically the everyday inclusion. All new nurses to the organization are enrolled in everyday inclusion. And then the cultural humility course is also a really, really good one. And then just the community education things that are kind of still in progress. We're just going to stay committed to our to the community cafe and meeting with the Swahili Women's Group. And we like to bring in like subject matter experts on specific topics. So we brought in somebody from the Breast Care Center to talk about mammograms. A couple of sessions had Dr. Sarah Guth, who focuses on maternal mental health. She's one of our psychiatrists up at UVM Medical Center. We're going to bring in folks from the language access department. We're going to bring people in from financial services. So we're just kind of continuing to meet and to see like what the needs are, what the point of interests are, and then just bring as much information around those topics as we can. And just really encouraging folks to just to get involved and have the courage to kind of speak up and advocate for themselves and to utilize us in that process whenever we can. Marge has also been doing chart reviews with patients who have like more complicated cases and have a lot of unanswered questions. She's been meeting with people one-on-one to really do an in-depth dive of their health history and just help people kind of explain what has happened to them and what current health challenges they're facing and why. And who's this one? I didn't practice this one. Probably we've already talked about a lot of it.
Yeah, this is Marge Meyer, who was really integral to this whole process. We're sad she can't be here today. And she was also sad, but she looked at the big picture, and thinking about as we focused these initiatives and the areas in which we were moving in. And it's around, identifying barriers and gaps, and so that we can make the experience when they interface with the healthcare system, predominantly in the hospital, which is where we see them, and how do we make that experience better given the information that we've been able to receive in these multiple ways. And so she organized it around the patient and understanding their body, the provider, making sure that they understand the necessary pieces around good interpretive services, asking the patient, the patient is the expert on their care. And that's true no matter what your patient looks like or what language they speak. That is where they are the experts. Asking them again around being culturally sensitive, but asking them directly, what is their goal? What do they want out of their care? And helping you to focus on their perspective and not just be a talking head around, what treatment options are available. Asking what they understand and doing that teach back, perspective so that they explain what they've heard from you, so you really get an understanding around how much they do understand and what you do need to continue to explain. And then navigating the healthcare system is the biggest square on here, because that's clearly, people that understand the system and speak the language, and even healthcare workers need help navigating our healthcare system. It's so huge and cumbersome. And so, just making sure that we continue, and that's where we feel so, happy to be involved in the Swahili women's group, because we're able to answer all these questions, and hopefully that knowledge gets disseminated out. And we want to replicate that in other areas, and working on the system, recognizing, taking the information that we've received and hopefully creating some changes and barriers to practice. Is there anything else you guys want to add that
I think that's good.
Yeah, just the last. Yeah, the last is our future vision. And so we went into this with an idea that was then validated through the focus groups and through the Swahili women's group around that they really wanted to see themselves in the people who are taking care of them. I remember at one point they said, can't you hire some Swahili speaking nurses? And, also identifying space in which they already felt trust. And, our coming into the AALV space or the family room space changes the dynamics, the power dynamics, right? We're there to learn from them and to ask them questions. And so it changes that trusting space. And so to be able to provide care in the space in which they already feel comfortable is crucial. And Andrea Green does that within the family room through Healthy Families. What's it called? Healthy Families from the Start. And we have this idea of going in there and providing wraparound pregnancy and postpartum care that would tie into her Healthy Families from the Start pediatric clinic. being able to do childbirth education, and maybe having cultural community workers or doulas, expanding the workforce so that they would be supported through their pregnancy, through their labor and delivery, and through their first 1 or 2 years postpartum with someone who understands their culture, who speaks their language, and is paid to do that. And so that's our pie in the sky dream.
Searching for the perfect grant. Let us know if you have any ideas.
And I can say just lastly, I think we've run out of time. 5 minutes. So I think a key element in this initiative is education and working together, collaborating. I don't just work at UVM, I also work with my friend I see back there, Alison, in disseminating videos and audios of things that are important for their daily living, understanding what to do if, say, your toilet floods, or who to get in touch with if you're looking for your landlord. Basic stuff that are not communicated to them when they arrive here, or if they are in that orientation. It's a lot of information to grasp and retain, because it's disorienting already. It's so cold. I went to a family's house one time in the dead of winter, and they had not turned on their heater. They didn't even know how to flick the lights on. They didn't even know where to put the food so that it needs to stay in the fridge. They just didn't know a lot of things. They were just in their jackets freezing, right? So there's really a lot of work that needs to be doing. So even as we talk about education, it's for both the immigrant groups who already need to navigate a complex and often marginalizing system, but for the healthcare providers. We need to unlearn what we thought we knew, and hey, we're ready to go. But we must learn to unlearn biases and broaden understanding of culturally competent care. So it's a dual approach. In my role in this group, is to connect traumatized women with clinicians who can either do group therapy or individualized therapy, depending on the severity of the trauma. But before that happens, it's a bunch of encounters and encounters so that we can build that trust. And when that trust has been built, then in the in-between, we introduce literacy, English learning classes, maybe financial literacy, maybe this. So it's connecting the essential workers around them so that they feel comfortable, and then the clinical work begins. So if there's anyone here who needs to come and say, hey, I got to talk to you, please call. I'm right here. This is one of the reasons I'm here. But this is all collaborative work. And we have to do it together for the common goal of bringing healing to our communities.
We have to acknowledge all of our funders and all of our partners who were not able to be here because we couldn't do this work without them. Dr. Marge Meyer, we've mentioned several times, Josh Miller and Dave Savio at the Family Room. Dr. Jan Shea in anthropology has helped with organizing focus groups and themes and helping us take an anthropologic approach, as well as several undergraduate students who've helped on this project, and funding from UVMMC, Vermont Department of Health, AALV, Dulce, and Vita.
Try 1 minute for one question, if there are any. Okay, thanks.
Oh,
Maria.
My last question. So this is amazing. So you've been doing this, and I was wondering if you were going to extend your services, what you're doing to other community groups in the immigrant community. I'm thinking my own community, but I was I'm asking for other immigrant communities.
That's the goal. Yes. Absolutely. Happy to talk to you. I have your email.
Let's connect.
Put in a plug at Chloe I use
UVMMC is the Family and Children's Program, and we do provide wraparound care starting prenatally through 2 years post. So I have a poster over there, number 21. If you guys can check it out.
Cool.
I'm happy to talk to any of you.
Thanks. Awesome. All right, thank you.
Thank you.
That's program. That's for your. Yeah. I do. Not in the wrong way. Yeah.